Hello, everyone. I'm Dr. Nidhi Agarwal. In the interest of time, we'll be skipping the coffee break, and if you guys can please sit down, and we'll proceed with the next lecture. So it's my honor and privilege to introduce the co-chair for today's meeting, Dr. Sara Suliman. She has been with the UAE Obesity Conference since its inception in 2018. And currently, she serves as a consultant endocrinologist at Imperial College of London, Abu Dhabi, along with heading the genetics and the obesity services here. She has co-authored several abstracts, several publications, and is internationally recognized. She has also written the type 2 diabetes guidelines for the Emirates Society, along with the GCC and Lebanon obesity guidelines. It's an honor to have you, Dr. Sara. Please, the stage is yours.
Can you hear me?
Yeah, it's on.
Good afternoon, and thank you very much for staying until the dregs of the day. I promise I'll try and speed through this. So I've been given the task of speaking about obesity in women across the lifespan. I'll touch on epidemiology, a little bit of why it's important, the risks of obesity in women. I'd like to focus on pregnancy and childhood because, as we've heard today, obesity is a huge problem. 1 in 7 people in the world today live with obesity, and 1 in 5 by 2030. So to try and break this cycle, we need to think about the next generation. I'll speak a bit about obesity in girls and the hormonal abnormalities associated with obesity. And at the end, I'd like to speak a little bit about the sex differences in the treatment of obesity. Sorry, in the middle, I'll speak about the complications of obesity in women. So, worldwide, women are more likely than men to be affected by obesity. So if you look on the right compared to the left, and this is the latest data on the Obesity Atlas, you will see that we have a darker view of life. It has also been steadily increasing, so compared to 2000 on the right, you can see that it is a much darker picture now. And why is it important to look at obesity in women? Women constitute about 50% of the adult population, and they carry for 9 months 100% of the population. So if you're looking at future generations, that's who you need to target. The in utero environment affects the future risk of obesity and many other diseases. Therefore, tackling obesity in women provides a unique opportunity to improve women's health, but also to stem the tide of obesity. So in women, the risk factors for development of obesity, some of them are the same as everyone else. Genetic background, environment, but actually some are unique, such as pregnancy and the menopause. And others are more prevalent. So in many parts of the world, women have a more sedentary lifestyle than men. Stigma associated with obesity is larger in women than men. So for example, if you look at France, the chances of having obesity as a woman are very slim, whereas the chances of having obesity as a man are much higher. And the reason is almost entirely put down to stigma, and that obesity is not acceptable in that environment. There are other disorders, such as autoimmune disorders, which are more prevalent in women and can limit mobility or are associated with obesity. Looking at disease risk, obesity differentially affects bits of women's health, such as hormonal abnormalities, or might have a more profound effect. For example, although there is a protective effect of being female, that effect disappears in women living with diabetes or with obesity. And the risk is therefore much higher, relatively, for cardiovascular disease, diabetes, and cancer. We've seen this slide before from Carl LaRue, looking at all the risks associated with obesity, some of which are particularly relevant in women, such as PCOS, an increased risk of cancer, fertility issues, and stress incontinence in older women. But it's not all doom and gloom. because as far as we can see, the benefits of treating obesity in women appear to be very similar to men, if not better. So if we look at the lifespan, we all have infancy, childhood and adolescence, adulthood, old age, but women have that extra cycle of pregnancy. And what I'd like to do is focus at the beginning on that loop. We know that in infancy, the risk of obesity is associated to genetic predisposition and the in utero environment. Obesity in general is a heritable disease. It's only the second most heritable trait. So when we speak about heritability, we're not talking about a particular gene. We're just saying, if your parents suffer with something or have something, what is the likelihood of you getting it? So if your parents have obesity, there's an 80% chance that you will have obesity. And we know that in monozygotic twins, food choice, the risk of obesity, response to overfeeding, dietary restriction is very heritable. We know that adopted children, and we've heard this before, resemble in thinness and fatness their genetic parents, even though they live in completely different environments. And even fat distribution is heritable. If we look at absolute genetics, we've heard about the causes, and there is syndromic obesity, which can result in early childhood or neonatal obesity. There might be mutations, or the vast majority is genetic polymorphism. So if we're looking at the sort of young onset obesity, it tends to be chromosomal abnormalities or monogenic obesity. But despite the heritable nature of obesity, the rate at which obesity is increasing cannot be explained by just genetics. So we're all descendants of hunter-gatherers. We carry genes that help store, but actually this epidemic is really going at a very fast rate. And one of the things that's postulated to happen is that we're being reprogrammed with epigenetics, which is the relationship between the genes and the environment. So it's where genes are regulated. We're all born with the same genes, and we die with the same genes. But why do they cause us to become more obese or not? And that is the epigenetics. It's kind of switching genes on, switching genes off. And I'll give you an example, which I quite like. So it's like playing the piano. You can either be fantastic, like Mozart or Bach, or you could be an amateur and play Happy Birthday to You with 2 fingers, like Sara. The music that comes out is very different, but the piano itself does not change. Similarly, pregnancy is the best example of epigenetic regulation. Every single cell in our body has exactly the same DNA. And yet through epigenetic regulation, sort of start a bit, stop a bit, we get a nose and an eye and a kidney and a liver with exactly the same genes. And that's the power of epigenetics. And pregnancy has this fantastic cycle where from one cell, it becomes an infant. And in the middle of that, not only do you have the imprinting of that gene from parents, that then gets removed, and you remember your parents and get some more of your own due to the in utero environment. So epigenetic regulation, as we said, can happen during the germline development, even before fertilization, during pregnancy, but also in early childhood. And what happens is that these genes are switched on, and they increase the risk of obesity in that offspring. And many of the environmental factors that we hear about as risk factors work through that process. So use of antibiotics in pregnancy, sleep deprivation, placental function, breastfeeding, many of the classic things that we never really understood how they caused obesity work through the microbiome, diet, early life influences, and many others resulting in type 2 diabetes and obesity. There are also others, such as drugs, toxins, nutrients, you name it. They all have an effect on the genetic background. And what that does is that baby, or that zygote, if you like, gets epigenetic regulation. That baby is born already having this message to be affected by obesity or diabetes. Postnatal factors make that worse. that mum then has, whether she has obesity, type 2 diabetes, reduced insulin secretion, conveys that message and more to the next generation. So we know, for example, that diabetes, obesity, and IUGR in famine situations all increase the risk of obesity in future offspring. But there is light at the end of the tunnel, and I alluded to that earlier. We know from bariatric surgery that this is a two-way street. Just like we can get messages that make us more likely to get obesity, if we treat the mum, we can take away that message and actually have healthier babies in future generations. So if we look at girls, moving on from early childhood, again, the risk of obesity in girls is higher than in boys. Not only that, we assess weight using percentiles for girls and boys. And if we put them together, you can see even for normative data, the absolute weight in girls is higher than boys. So this should have come a bit earlier, and I apologize about that. So this, again, supports the notion that in the first 3 years of life, if you have normal weight versus 25% or 50%, the likelihood of developing lifelong obesity is significantly increased in those who maintain weight above 50% the normal weight after 3 years. So the magic number is 3 years. By 3 years, if they have not managed to lose the weight to near normal, so even if it's 25%, the risk of obesity long-term is not as high. However, once they cross that 3-year mark, the risk of obesity is maintained lifelong. Obesity in adolescence is associated with many of the risks of adulthood and some more. So raised intracranial pressure is a very significant risk in childhood. Slipped femoral epiphysis, pain and difficulty in walking, hyperandrogenism, premature menarche, and we'll speak about that in a minute, huge psychosocial effects, menstrual irregularities and polycystic ovarian syndrome, but also an increased risk of cardiovascular disease and cancer long term. And this is looking at cardiovascular disease, young girls who have a body mass index which is less than 50% higher than normal, have a slightly increased risk of cardiovascular mortality, whereas those who have a body mass index of over 95% have a 140% increased risk of cardiovascular disease by the age of 40. If we look at hormonal disturbances in children, childhood obesity is a risk factor for early puberty. So those with severe obesity at the age of 5 had a 2/3 increased risk of early breast development and were 2.5 times more likely to have their periods before the age of 12, resulting in short stature, metabolic abnormalities, mental health issues, and all sorts, as well as early pregnancy. Thankfully, not a big problem in this area. In adults, early puberty is a risk factor for some cancers and is associated, as we saw, with premature cardiovascular disease. So polycystic ovarian syndrome is a chicken and egg situation where obesity worsens hyperandrogenism and worsens PCOS, and the increased hormonal effects then increase hyperinsulinemia and increase obesity, and breaking that cycle seems key. We know that in women living with obesity or young ladies living with obesity, there is increased insulin resistance, oligoanovulation, impaired response to fertility treatment, and reduced success with ART. And even when they get pregnancy, they have 3 times as much miscarriages. If we treat obesity, we improve PCOS symptoms and fertility, and the target at the moment is a weight loss of 5 to 10%. Calorie-restricted diets and exercise are still first-line options. However, bariatric surgery has the best evidence, so the Bambini trial was published last year, showing that there is a 3 to 10 times increased ovulation rate in those who have bariatric surgery compared to those who have best medical treatment, fertility treatment. GLP-1s are used uniformly by obstetricians, However, there is no evidence for them. So I think we need case-controlled trials to tell us. And metformin has been in the background for 1 million years, and I think the evidence is just not very clear. What about obesity in adult women? There are many factors. We spoke about hormonal changes in puberty, pregnancy, and menopause. There's a higher proportion of body fat in women, and the lean mass, the increased fat to lean mass ratio predisposes to obesity and obesity recurrence. Socioeconomic status in many parts of the world, women have lower income and lower educational levels. Stress, depression, emotional eating, body image, disordered eating are all more common in women. And there are unique challenges. Women have caregiving responsibilities, they have time constraints and work-life balance, limited opportunities for physical activity, sleep deprivation, you name it, it all piles up on mum. And therefore, addressing these complex factors requires a multifaceted approach, including promoting gender-sensitive public health policies, educational program, and supportive environments for women to make sustainable changes. What about pregnancy? Pregnancy is a key driver for obesity in the mum, but also a key driver for obesity in the child. And high birth weight predisposes to childhood obesity, as we spoke earlier. Women with overweight and obesity result in larger babies independent of gestational weight gain. And similarly, gestational weight gain alone, even in women who have a normal body weight at the beginning, results in large gestational age babies. So looking at women who gain an average, I'm hoping that will go back, here we go, an average of 10 kilograms, the risk of a large gestational age baby is only about 5%, whereas if they gain 30 kilograms, which is well outside the normal range, they have an almost 40% risk of a large gestational baby and imprinting to actually increase that in future generations. Obesity itself results in higher maternal mortality and complications, gestational diabetes, hypertension, preeclampsia, obstructive sleep apnea. What about menopause? So obesity risk is increased in the perimenopausal period, partly due to changes in mood, reduced activity, worsened food choice, adverse changes in body composition and fat distribution, and also cardiovascular risk factors are significantly changed with menopause, including an increase in LDL and ApoB. So we spoke about some of the complications. What about the metabolic differences between men and women? Men in general have increased muscle mass, increased visceral adiposity, increased need for oxidation at rest, whereas women have an increased total fat mass, increased subcutaneous adiposity, which is associated with better insulin sensitivity, but need for storage or non-esterified fatty acid storage at rest. And therefore, in men, we tend to see higher fasting glucose, whereas in women, it's the postprandial glucose, which is better associated with cardiovascular risk, which tends to be increased. If we look at women and the risk conferred by obesity, so this is looking at healthy women, aged 35 to 55 from the Nurses' Health Study, those with a BMI of less than 22, compared to those with a BMI of more than 35, there's a 100-fold increase in the risk of diabetes. What about cardiovascular disease? Cardiovascular disease is still the leading killer of women in the US. Obesity is only the second risk factor after family history in the women living with obesity and cardiovascular disease. There are unequal standards of care, so women are more likely to die in the year following an MI than men. Women are more likely to be misdiagnosed with an MI than men. And 64% of women who die suddenly will die suddenly of ischemic heart disease with no preceding symptoms. So again, we need to target a lot of effort in that. What about cancers? Obesity predisposes to cancers, and we're looking forward to a lovely talk tomorrow. Please do come on obesity and cancer. There are 13 types of cancer which are associated with obesity, many of them more so in women, such as breast, thyroid, meningiomas, endometrial and ovarian cancer. Obesity negatively impacts all stages of cancer management. So it's associated with an increased risk of developing multiple types of cancer. The detection and diagnosis isn't easy because of their size. Patients are stigmatized. They don't want to come up for screening. Some machines do not carry beyond a certain weight. Cancer treatments tend to be adjusted for weight and have a maximum dose. So these patients get less dosage than people who carry less weight. And obesity worsens the quality of life in people living with obesity and increases the risk of cancer. So we know that the mortality in women is higher relatively than men, but actually for both men and women living with obesity, mortality from cancer is higher than people who have carry normal weight. We know from earlier studies that following bariatric surgery, the Swedish obesity study is the mainstay of bariatric surgery studies, that there is a reduction in cancer mortality following bariatric surgery, more so in women than men. And this was confirmed recently with a Splendid study where this included a US health registry between 2004 and 2017, and it showed that there was overall a third reduction in cancer risk and a half reduction, or 48% reduction in cancer mortality. The more weight you lost, the more the incidence of cancer was reduced. So in those who lost over 40% of their weight, it almost normalized their risk of cancer. But again, when we look at women, bariatric surgery, whereas with men, it crossed the line of unity. With women, it's very clearly beneficial to have bariatric surgery to prevent cancer and cancer mortality. So we now have a plethora of medications to treat obesity, and with many of them, or the studies have been going for many years, there are actually no studies to tell us, do these medications work better in men, better in women? That analysis hasn't been done. There was a poster presentation at the EASD showing that tirzepatide has better weight loss results in women compared to men, so between 11 and 27%, as opposed to 9 to 19% in men. And this was a summary from the SAMANT 1 to 4. However, there is not sufficient evidence now to say that that medication works better for women versus that medication works better for men. What about bariatric surgery? About 70% of individuals who undergo bariatric surgery are women. Weight loss response is similar. Women are more likely to have corrective procedures following bariatric surgery. And although they have better metabolic effects, they tend to have worse psychological outcomes, lower body image, higher rates of depression, and lower satisfaction with the operation. However, their risk of diabetes, hyperlipidemia, and sleep apnea are improved compared to men. So in conclusion, obesity in women is a large and increasing problem with complications at all age groups. Treatment options work well in women, and therefore, with comparable side effects, there's a lot to offer and no excuse to do nothing. Epigenetics accounts for the majority of heritability of obesity, but is reversible and provides a genuine target for obesity prevention. Young women of childbearing age, pregnancy, and early childhood are critical periods for the epigenetic programming of an individual and their future offspring. And therefore, to combat the wave of obesity at the moment, and we have very few answers to how to flatten that curve or try and get rid of it, that's who we need to target. I'm very lucky to work with a huge team, many of whom are here, who provide a holistic treatment for obesity, including my co-chair and partner in crime, Mohammed Haddad, Dr. Tawfiq, who's a pediatrician, who's excellent, and many, many colleagues whom you've heard present today. It's an honor and privilege to work with them, and I'm happy to take questions. Thank you.
Thank you, Dr. Sara.
And of course, all of us focus on number one, the patient.
Any questions? I have a question, Dr. Sara.
Go on then.
You don't give us a lot of hope for women, but in terms of epigenetic programming, if there is someone with an identified genetic mutation in their family, is there any role of IVF in selecting those embryos to sort of rule out those or remove those genes from their code?
So that's an excellent question. Embryo selection at the moment is used for diseases that severely limit life expectancy or have severe disabilities, and therefore obesity doesn't quite qualify in that. There are forms of obesity which are associated with other chromosomal abnormalities, so Bardet-Biedl, or in which case, yes, you can definitely try and select out. But I think for obesity per se, monogenic obesity, particularly now that there are more treatments coming out that can target monogenic obesity, it is not a cause for embryo selection.
Thank you. Can I ask one more question?
Sure.
If there's one. Do you have a question? Please, go ahead.
I have 3 questions.
Oh my goodness, I'll try.
On obesity, so setting of our weight. So that's one question. The other thing is fertility and GLP-1. You share some, anecdotal experience. And then when you go into the slides about girls and women, I don't know why it wasn't matching with women. So the obesity, distribution in the countries. So if you can look at the countries, what happens when the girls go to stage of becoming women, where the obesity in these countries exponentially goes up? So these are the 3 questions.
Okay, so I'll try and answer them in order. Oral contraceptive pill, very important. There was no space to put everything. But yes, it is associated with an increased risk of obesity. Obesity is associated with increased complications of the oral contraceptive pill, such as DVTs, hypertension, everything else. So when you're looking at a woman living with obesity, you need to consider carefully what type of contraception you're going to use. I've forgotten the second question already. Yes, GLP-1s and fertility. Watch this space. I think someone needs to do the study. I mean, it is so common that people who lose weight, so we know, for example, for bariatric surgery, that it increases ovulation by 6 to 10 times. We're now using medications that are almost as good as surgery. So one imagines that's the case. We've heard about Ozempic babies and all sorts. And in our own setup, we have many patients who had been trying to conceive for many years, and therefore they do not use contraception because they assume that they will be fine and come back and say, I'm pregnant, what do I do now? But I think we do need case-controlled studies.
The third one was the girls and the women.
Yes. So
what happens when they become women,
yeah.
where there's an exponential increase in obesity?
Yes. Yes. So for multifactorial or polygenic obesity, the risk is increased almost 100-fold for children who, beyond the age of 3, have obesity. And therefore, there is a lot of overlap between countries that have adolescent obesity in women or in girls and adult onset obesity.
I think we'll take one more question.
Yeah, regarding over here, regarding...
Can we take 2?
Breastfeeding and obesity. In our society, we're struggling with that issue, and it's a major issue. In the clinic, we see our patient who breastfeed, their weight goes up markedly.
So yes, obesity, so first of all, speaking about the baby, breastfeeding the baby is better for the baby. They're less likely to have obesity when they grow up. Speaking about the mum, there are small things that make a big difference in obesity management. I know we said that lifestyle only contributes about 5%, but there are some bits of lifestyle that contribute very significantly, of which sleep and hydration are very important. So mums who've just had a small baby do not sleep. All the women here will tell you that. And adequate hydration often doesn't happen because breastfeeding makes the mum slightly more dehydrated. That's one factor. The second thing is that women get hungry when they breastfeed, and the food choice tends to be not great. In our region, it's not helped by cultural things, shrabi hilba, مش عارف ايه, it's problematic. So you are right. Breastfeeding period is well associated with obesity, particularly in this region.
I'm sorry, we'll just take one last question. And we have 1 minute for this.
Okay.
Thank you very much, Sara. It's really wonderful to talk. two things. In fact, Dr. Mohammed Haddad is here. Those women who are seeking pregnancy and get bariatric surgery, and then they get pregnant because they don't take any contraception. To treat them in the first few months after bariatric surgery is a nightmare for us. So I think you should have somebody, an obstetrician in your team, who could advise these people really that it is beneficial for them for a safe pregnancy. Second thing, and now with the era of GLP, that when do you advise women to stop it to get pregnant?
Okay, so the first question is post-bariatric surgery pregnancies, and everyone has these stories. Thankfully, not that we would ever recommend it. We say that at least for the first 6 months, use adequate contraception, probably for the first year until they are nutritionally stable. We've had a few. They've managed to make it through not too badly. I wouldn't recommend it, but I agree. That advice is given in writing. They're told it. I don't know. I mean, the other issue, which perhaps is a problem for Mohammed Haddad and his team, is that to get a positive pregnancy test takes 14 days. And therefore, we've had one case, which was scary enough. I hope we never have another. Although a pregnancy test is done on the day of the operation and 2 days before, this lady was still pregnant on table. And she's done really well, alhamdulillah, but it is scary when that happens.